Hi, this is Dr. Jackie, GP. Today we're discussing blood pressure, about what we need to know as a continuous personal development, focusing on blood pressure for as GPs and what we need to know for our patients. So basically, hypertension, I figure this as I teach this and I'm listening to it myself, and it'll be good for the listener and for myself as we study this, go through this material together. So hypertension itself, it's good to know that it's not a disease. Hypertension is a risk factor for cardiovascular disease. What more, unlike age and sex, it is a modifiable risk. So that's a very important factor. It's a vital thing to tell our patients that the blood pressure that they have, hypertension, is a modifiable risk factor. They can control it. So why are we talking about blood pressure and why does it matter, hypertension? So much of our understanding on hypertension is based on trials that are often decades old. A massive study reviewed contemporary data on hypertension and challenges some of our assumptions, in quotes. The study looked at 1.25 million people over the age of 30, and none of them had cardiovascular disease at the start, although 25% were on antihypertensives. You'll find that in the Lancet 2014, pages 383. The study showed the following. There was no J-shaped curve for blood pressure. Those with the lowest blood pressure are not at increased risk compared to those with blood pressure of 90 to 114 over 60 to 74. Remember that in Europe, many of these individuals are often treated for their low blood pressure to make it higher. Those who develop hypertension, that is a blood pressure of 140 over 90 and more, developed cardiovascular disease 5 years earlier than those without hypertension. They also found that the commonest hypertension-related diseases, related diseases people developed were heart failure and angina. The attributable risk factor for hypertension varied from one cardiovascular disease to another and varied whether the systolic or diastolic blood pressure was raised. So, for example, high systolic blood pressure increased the risk of getting angina and intracranial hemorrhages or strokes. The most, whereas the risk of developing abdominal aortic aneurysm was linked much more with a diastolic blood pressure, with high diastolic blood pressure, and with little impact from the systolic blood pressure. So that's why it matters. We need to know that. Again, from 1994 to 2011, they did a cross-sectional study in England, which is shown you find this in the Lancet 2014. He found that the average blood pressures for those with hypertension has fallen. It's a good news from 150 over 80 to 135 over 75, and the prevalence of those with controlled blood pressure doubled from 33% to 63%. So GPs in England, obviously we're doing something right because of this sudden improvement in blood pressure control. So it's okay. So we need to give ourselves a pat on the back there. However, they found that a survey of about 300 GPs found that more than half GPs in 2015 were not using the correct thresholds in making the diagnosis of blood pressure. Most of them were using higher thresholds, therefore underdiagnosing hypertension. And especially in part this was because they were adjusting by the 10 over 5 for home readings as we used to, but now we shouldn't anymore. This was, you can find this in the BMJ and the BGGP 2016. So it's time to check our protocols on our diagnosis. Are we still adjusting, or do we take the readings? So let's discuss here patient's view. What are the patient's view on hypertension, and some of the questions they ask? Yeah, what's the patient's view on hypertension? What do patients think about the hypertension? So we find that some patients, there was a systematic review of the literature raised some important points. You find that in BMJ 2012, I think page 345, or that's what it is. It says patients think, this is what they think. They think, number one, that the main causes of the hypertension is stress, food, obesity, family history, and alcohol. So that's their patient's belief. That's what they think about their blood pressure. Stress in particular was identified as a key element, as a cause or an exacerbator or as a consequence. That's what they felt. The other thing it was found in the studies that many described trying to avoid stress after their diagnosis. That is, they say they're going to avoid arguments, they'll change their jobs, they'll try and relax more. Some even thought that hypertension was a temporary illness and that it would resolve. Okay, this is a patient's view on hypertension. And again, most knew that hypertension causes stroke and heart disease, but few of the patients knew that it can actually affect their kidneys. So the main symptoms patients associated with hypertension were headaches and dizziness. And most felt that the absence of such symptoms showed good disease control. Many had experimented with stopping treatments to see if any symptoms recurred. So lack of symptoms often prompted patients to stop medication, and the presence of symptoms encouraged compliance. Wow. So many expressed a fear of that long-term medication was harmful and perceived was harmful, and there was a risk of tolerance, dependence of or the drug building up to harmful levels in them. The alternative medicines were widely used and perceived to be more effective than the medications we were offering. So it's worth bearing this in mind the next time we do a medication review, 10 minutes, or our newly diagnosed patients, to discuss these points and their health beliefs about blood pressure, and so we can help improve their management of their blood pressure. So, and again, also these are some of the questions that patients also tend to ask. My parents had blood pressure, have hypertension. Am I at risk? So data from the Framingham cohort suggests that the family history does have influence, but age matters. That is according to BMJ 2017. The study showed that those whose parents had developed hypertension before the age of 55 were at increased risk of developing hypertension themselves, double the risk if one parent is affected, and 3.5 times risk if both parents are affected. So those whose parents develop hypertension after the age of 55, were not at an increased risk of hypertension. Okay, so that's what we'll tell our patients there. Okay, so the other questions patients ask is that I had hypertension in pregnancy. What is my risk of developing hypertension later in life? So it is well known that women who have hypertensive disorders in pregnancies, that is gestational hypertension or preeclampsia, eclampsia, or HELLP syndrome, are at increased risk of developing hypertension later in life. A massive cohort study has now quantified the risks and looked at how quickly hypertension recurs. You find that in BMJ 2017. The conclusion is that about a third of women with hypertension in pregnancy develop hypertension later in life. Again, they found that the hypertension may present as soon as 1 year after delivery. So another cohort study looked at women who had hypertension in pregnancy to identify what factors increased the risk of hypertension in later life. You find that in BMJ 2017. The main risk identified was obesity. The researchers estimated 25% of all causes of hypertension in later life were attributable to obesity, and modifying lifestyle to reduce obesity would reduce the number of women who develop hypertension in later life. Okay, so these accompanying editorials reminds us that women who've had hypertension in pregnancy, they need regular monitoring, but it doesn't really specify, when, how often they should be monitored. Okay, you find that in BMJ, British Medical Journal 2015. That was in page 358. So the thing we should ask ourselves now that do we code hypertensive disorders in pregnancy? How do we ensure that we monitor these women for hypertension? Should we do this as an ad hoc, or do we want to be more proactive? There's something, as a practice, with GPs, we can decide to manage these women properly, so we can pick up blood pressure, increase blood pressure. Okay, the other thing I wanted to discuss in this video is about poor compliance with medication for patients who are on blood pressure medications. So that within the 10 minutes consultation that we have for medication review with these patients, I think you can explore 6 things. There are 6 things we can explore in this 10 minutes consultation. I try to put a mnemonic as 3 R's that you look at explore the reasons for why they're not taking medication. We should ask and listen. So R1, the first R is reasons. And the second R, we should discuss risks. Risk with the patients. Why for using the Q risk, for example, to discuss their risk factors with them. The other thing we can do is that we can look at rationalizing their medication for them, so we make it easier, or see what we can reduce, or make it easier for the or changing, so we can reduce the side effects for the patients. Okay, and then those are 3 things. Then the other thing we can do is discuss the benefits of the lifestyle. The 4th thing we can do is discuss the benefit of lifestyle changes, and which may result in them needing less medication to treat themselves. And we also encourage home blood pressure monitoring. But if you encourage home blood pressure monitoring, it is a way of empowering patients to take control of their blood pressure. We can also use motivational interviewing as a way of empowering people to improve adherence to medication. Yeah, so we can use motivational interviewing. Okay, we said one of the methods that we use is motivational interviewing. Just a recap in case you don't remember what motivational interviewing is. The definition of motivational interviewing had been involved and refined since the original publication on its utility and approach as an approach to behavior change. The initial description was by William R. Miller in 1983, developed from his experience in the treatment of problem drinkers. Through clinical experience and empirical research, the fundamental principles and methodologies of motivational interviewing has been applied and tested in various settings, and research findings has demonstrated its efficacy. Now, motivational interview is established as an evidence-based practice in the treatment of individuals with substance use disorders. So when you're doing this with our patients, motivational interviewing, we should focus on exploring and resolving ambivalence, and it centers on the motivational processes within the individual that facilitate change. So the method differs from more coercive or externally driven methods for motivating change, as it does not impose change that may be inconsistent with the person's own beliefs, own values, or wishes, but rather it supports change in a manner congruent with the person's own values, or concerns. So the most recent definition for motivational interviewing in 2009 is a collaborative, person-centered form of guiding to elicit and strengthen motivation for change. I'll say that again. It's a collaborative, person-centered form of guiding to elicit and strengthen motivation for change. Okay, so I probably will do another video on just motivational interviewing, but for today is just so that is one of the methods we should use when you're trying to change, technique we can use in changing when you're trying to discuss poor compliance. Okay, I'm going to end this video here, and then I'll continue in the next video. So, because I don't want to make these videos too long. In the next video, we'll keep on discussing about high blood pressure and GPs and how we can help our patients. Thank you for listening, and I'll see you in the next video.